Welcome to Ostomy 101 and Troubleshooting. This presentation will outline the different fecal diversions and urinary diversions. The Hollister CE discussed one piece and two piece. What I like to start with is having you look at the right lower quadrant of your abdomen, and that is where an ileostomy would generally be placed. Not always, but if we are in a perfect world, an ileostomy would be placed in the right lower quadrant. This is where the most output or effluent is what we would call what comes out of ostomies. In this case, it would be bowel. This is also high output. It is acidic content, low odor, because it's coming from the ileum. These are also very small ostomies, and so food tends to get stuck here. So we have to tell our patients to chew their food really well, and we have to tell our patients to use either paste strips or paste to protect the peristomal skin, the skin around the ostomy. Now, if you move up, the ascending colostomy, the effluent starts to get a little bit mushier, but it's still pretty fluid in content. Also, not a lot of odor or gas going on here. Still looking at needing paste or paste strips. When you move over into the middle of your abdomen, you've got the transverse colostomy, and this is where a lot of emergency stomas are placed. So like a gunshot wound, or if somebody has a ruptured diverticuli, this is an emergency surgery to divert bowel, and typically within 3 to 6 months we do a takedown surgery to reroute and put the colon back together, and it's not a permanent stoma for this patient. These are also typically the largest stomas that you will see, and they are right in the middle of the abdomen, and they require a bigger pouching system because they are rather large, because they were made in an emergency. They do have more gas and more odor, and it is really a mushy consistency in terms of effluent. Then moving down the left side of your abdomen, you have the descending colostomy. We're starting to get more like what our real stool looks like. The effluent is more solid, and the consistency is certainly not as liquidy at all, and you've got more gas in your pouch, so that they have to use the phalange if they've got the two-piece to let the gas out. Definitely looking for more two-piece pouches, but by the time you get to transverse, descending, and sigmoid, sigmoid not necessarily, I'll talk about that in a minute, but when we talk about the one-piece and the two-piece systems, you really would prefer to have your patients having the two-piece to where they can release the gas. Whereas on the other systems, a one-piece might be fine as long as they're able to empty frequently. Moving down to the sigmoid colostomy, that is the only ostomy that patients should be irrigating, and they can be taught to irrigate once a day for what is considered continence, even though they really aren't continent because they don't have any feelings there, but they can use a sleeve and irrigate and have a bowel movement in the toilet once a day, and then they can use like a cap or a little one-piece block pouch just to cover that stoma up. Some patients even just use gauze over their stoma, so I would certainly recommend that they use a cap or just a little block of a pouch just to keep that covered in case something happens. But that is what you can do with a sigmoid. It is the effluent that is closest to the rectum, so therefore it is solid stool that comes out of that ostomy. Urine and lots of gas, and so lots of odor, more bacteria. not as caustic on the skin, so they don't necessarily have to use the paste or the pasting strips to protect the peristomal skin. Urinary diversions, we might have an ileal conduit, and that's where they've removed the bladder and they have placed some ureters, to ileum. They've basically made a bladder out of the ileum. And then they would do the same thing with a colon conduit, and then they have pulled a little stoma through the skin. And then we pouch those as well. And instead of the effluent being stool, it would be urine. The presentation will go over some really common peristomal skin complications and how we manage those. Pyoderma gangrenosum isn't really common, but it is something I've seen in practice, so I'll share that picture with you and talk a little bit about that. Peristomal hernia is extremely common, especially with those sigmoid colostomy patients who do irrigate. Stoma prolapse is common, especially in the pediatric population. Stoma necrosis is common after surgery, as is cutaneous junction separation. Flush or retracted stomas is something that's extremely common for an ostomy nurse to have to deal with, and we'll talk a little bit about products as far as what we do with that, because sometimes you don't get that perfect ideal stoma, and so that's where an ostomy nurse comes in. Stoma laceration can occur pretty easily because there are no nerve endings and the patients don't feel it, so it's just like having a cut in your mouth. Chemical or mechanical denudement or irritation is very common, and that is something that you might deal with and see in your own practice, and it's an easy fix. And then pseudoepithelial hyperplasia is the most common complication that we see with patients who have ostomies that produce urine. So that is kind of a crystallization, and it's pretty easy to fix by just having them balance out their urine and get it more on the acidic side. So I'm going to show you what these look like. First, this is an ideal stoma. You won't see this very often. It's beautiful. It looks like the inside of the mouth. If you were to clean this with normal saline and a gauze, you might get a little blood on the gauze and the patient would be concerned, but that would be okay because it should have lots of blood flow, and it cuts very easily, just like the inside of your mouth would. You can see the opening, or sometimes we call that the exit or the mouth, and that's where the effluent would go out and down into a bag, and so it's also protruding, which is what we like. You can see that the peristomal skin, or the skin surrounding the stoma, is all nice, clean, and intact. So these are all really good things. Our stomas don't always look ideal, and it's not always the surgeon's fault. It is the last thing that they are doing, oftentimes in a very long surgery, and our abdomens are not perfectly flat, and our patient population may have a lot of subcu tissue that they are trying to pull this piece of bowel through, and so therefore we end up sometimes with some odd shaped stomas. And so as a stoma nurse, we just have to use the products and things that we have to deal with that. Now, one really cool thing that a stoma nurse can do prior to surgery, if it's not an emergency surgery, is mark where the stoma goes, and we have patients lay down, sit up, go forward, and we try to keep that placement out of their abdominal folds so that it can be in the best place to have that flat plane surface so that they can get the best placement for quality of life purposes. But in general, what happens is we get what we get, and then we make it work for the patient so that they can go wherever they want to go, swim, go to water aerobics, run, do whatever they need to do. Lots of patients have stomas, and no one needs to know unless they want them to. This is a pyoderma gangrenosum. This is not a common complication, but it is one I wanted to share because I did take care of a patient that had this, and it is a very violaceous color, so that's how it kind of gets its name, and it looks almost like bite marks around the peristomal skin. And you can see also in this picture that this patient required convexity. They don't have that nice flat plane. So when you have convexity, it is pushing against the abdomen to help pull out the stoma. And what we did to manage this was we used a silver alginate to fill in those wounds, and then the patient had to be on high doses of steroids. That helps heal the wounds, but it doesn't solve the problem because pyoderma gangrenosum is a secondary cause. You have to figure out why they had this, and it's usually due to some autoimmune process. It could be due to a cancer, it could be due to Crohn's disease, it could be due to a variety of different things. And in this patient's case, I believe that she had a really rare autoimmune disorder, and so once they identified that and treated the cause, then she did not have pyoderma gangrenosum outbreaks around her peristomal skin. This is a peristomal hernia. This is a very common complication, but it is most commonly seen with patients who have that sigmoid colostomy, and it's somebody who's been irrigating for years. It is something that we can use a belt, and I'll show you that on the next slide. It's something that we can certainly deal with in a non-invasive manner. They are not allowed to irrigate anymore because that could complicate the hernia. If they do want to continue irrigating, they can have the stoma replaced, or not replaced, but they can have a corrective surgery and have it moved to the other side. And so that is one example of why stomas, while I talk about the ideal placement, and that's great for NCLEX too, is that if you are in the chart and maybe you got what should be a sigmoid colostomy and you're having high output, maybe it's an ileostomy, because you know, you can go into the chart and see what the surgery actually was, because maybe it's not located in that ideal spot because something happened in surgery. So always good to note that if you're having output that doesn't match what it should be on the abdomen as far as the location and what it looks like, that could be what's going on. This is the non-invasive way to deal with a peristomal hernia. The belt, obviously the hole goes over the stoma, and then the belt helps to give some support, and it also presses up against the abdomen to kind of help pull that stoma out. And the appliance, whether it's a one-piece or a two-piece, is held in place with the belt as well. And then the patient just isn't allowed to irrigate, and they go on with their life. This is a stoma prolapse, and you can see that this is a kiddo. It is most common in peds because of the extra abdominal pressure that is placed when they cry. They would be at high risk for a stoma laceration. Again, no nerve endings in that stoma. We have to use larger devices to contain the stoma. It can be digitally pushed back into place, and sometimes there are some devices to kind of hold that in place, but honestly it's really usually just protecting that stoma, because once they cry it just is going to push back out. And typically these types of stomas are for diverting stool and are not going to be permanent, and so that's what a stoma prolapse looks like on a kiddo that has been crying and exerted that abdominal pressure. And so our biggest goal here is to keep that from getting cut, so we're going to protect it. This is a stoma necrosis, and this one is bad. If this was only on maybe half of the stoma and you could still see some red and pink, we would think, okay, then this will slough off after a new surgery, and we would just keep a watchful eye. But this is a full necrosis, and so this patient needs to go back to surgery, and the surgeon will have to reestablish blood flow. So it does depend on the amount of necrosis. So if it just starts to turn a little bit, then maybe it is going to pink back up, and a little bit of the necrotic jelly tissue will just slough off. But in this particular case, we've lost blood flow and we've got to go back to surgery. This is a mucocutaneous junction separation. Sometimes, depending on the stoma type, there is a rod placed underneath the stoma to keep this from happening. Sometimes that didn't happen, and you can see that there is even some erythema occurring around the edges, so signs of inflammation. You can see some slough. That yellow tissue is necrotic tissue. And so to get this to heal, we would just be filling in the dead spaces, probably with some alginate, and then we would cover that up with some hydrocolloid, which is really, the funny thing is that how we discovered hydrocolloid is from the backing that is on ostomy pouches, and then we would cover it, so really we wouldn't have to cover it with hydrocolloid. We could just use the ostomy pouch itself to cover the alginate, the backing, and then that would heal up, and we would just be watching that so that that would heal in, and then we would monitor it until it all filled in, granulating from the bottom up, and of course monitor for any signs of infection. Right now it's just in the inflammatory process, but that's what it is, just separating the wound edges. This is a flush stoma. Surgeons used to make all stomas flush because we thought we needed to irrigate everything, but we have learned that the only thing that we should irrigate is the sigmoid colostomy. I have been called into ERs or hospitals sometimes to help out with a ileostomy that is plugged, and so like patients that eat popcorn or lettuce, or they're not chewing their food very well, sometimes get food plugged up in a little tiny ileostomy. So I don't ever tell people that they can't have what they want to eat. I just tell them to drink lots of fluid, and they need to chew really well, and then if something gets plugged, we again try to go as non-invasive as possible with those iles and have them try to knee to chest it, and take warm baths and move around and see if they can pass it that way. And then if they can't, there is something called a lavage technique where we use a syringe to kind of gently put some water in there and coax that food particle out. But it's not the same thing as irrigation. Another way that we can get flush stomas is with the urostomies. They're kind of difficult not for those stomas to turn out flush, and so we can use convexity for any time when we have flush stomas that we need to protrude so that we can get the effluent to go out and down into the pouch. And that's really our goal, is when you see a flush stoma, that's not what we want, so we're having to use convex products. The reason that you would go from one piece to two piece, and I know that they say this in Hollister, but the one piece is nice and flat, and so people feel like they like that, not being able to see it under the clothing. But the idea of having the two piece is that you can switch parts in and out, and so that's a really nice, convenient thing for patients as well. So unless they have, if they have gas, I'm really sticking with the two-piece because it's got the phalange that they can lift up to let the gas out. One of the things patients like to do is poke holes in the pouches, and so I'm really particular about not letting them do that because that negates everything. This is a retracted stoma, and they're also going to require convexity. This is a little bit more complicated than that because this is where our friends like paste and paste strips come into place, because you've got to build up this flat plane. Not only do you have to push against the abdomen to pull the stoma out, but you've got to have a flat plane or you're going to have stool leaking all in around these abdominal folds. So that is the art part of being a wound ostomy nurse and giving someone their life back that thought that they couldn't get out of the house, and so teaching them how to do that piece. This is a lacerated stoma, and you can see erythema around this stoma as well, and in this case the patient just got their device cut too close and they did not feel it, and it lacerated into the stoma or bit right into their stoma. So just like if you bite into the side of your mouth, really all we had to do was to resize, and you can see on the card there it says ileostomy, so we had to resize for them and teach them how to cut that out properly, and it just heals on its own. This is denudement. It is not excoriation. Excoriation is linear scratch marks. That's a pet peeve of mine because lots of nurses will call this, even on a buttocks, excoriation, and this is denudement. And this is around the peristomal skin. This is probably the most common thing that you will see, and it occurs 7 to 8 weeks after surgery. The patient goes home, and they come into the wound ostomy clinic, and their stoma has shrank because it was enlarged after surgery, and now they have denudement around the area because they kept cutting out the pattern the same way instead of remeasuring their stoma 7 to 8 weeks after surgery. So we put some ostomy powder on that and brush it off and help them remeasure and have them continue remeasuring until we are sure that that is shrunk down the way it's going to shrink down, and it will heal right on up. This is an obvious contact dermatitis. This patient looks like they have exactly the pattern of their ostomy appliance around their stoma, which means they are allergic to it. This is rare, but there is only one company, and it is called New Hope, and they are the ostomy product, the only ostomy product on the market for patients who have allergy issues with ostomy products. Right around this stoma, this is going to be a stoma from an urostomy or colon conduit, and that is going to be one that produces urine. They have gotten it too wet, and they don't have urine that is acidic, and so they get what's called pseudoverrucous lesions, or PEH, and you can also Google image these because sometimes they look like warts even. They can be kind of whitish gray, and we can use something called a silver nitrate stick to kind of burn those down and get those flat. But the biggest thing that we can do, of course, then is remeasure the ostomy device to make sure that we've got the pouch size cut out correctly. But then we're going to have the patient drink lots of fluids, make sure they probably are drinking some cranberry juice, get that urine on the acidic side, and make sure that it's not on the ash side, because what it is it's crystal formations in the urine. And if they get that urine too alkaline, then they get pseudoverrucous lesions forming on the side of the peristomal skin. The other thing I would mention is if you ever have to get a urine sample from a urostomy, you are not to take it from the pouch, but you are to use a straight catheter kit and take it from the stoma. If you take it from the pouch, you will get a UTI every time from the urine that you've got because it's contaminated urine, so it does need to actually be taken with a straight catheter. This is just a reminder on irrigation, and I'm going to try to have an irrigation kit for us on our lab day. But when, who, what, where, how, I always just like to answer those questions. And if anybody's asking you to irrigate anything besides a sigmoid, then you shouldn't be doing it. There is a special cone sleeve device, and what water goes into it should be coming out in stool in the toilet. If it's, we should be measuring what comes in, goes out. If not, that is kind of where we're coming up with these peristomal hernias too. Patients, once they learn how to do this for their sigmoid, can do it once a day, and that does give them a lot more freedom because they should really just be having that one stool a day. The complication, of course, is the peristomal hernia, and it can be from improper installation or irrigation. When we do this, there is this cone kit, and we, of course, use proper lubrication, and we digitally dilate the stoma, and then we use the lubricated cone, and then we fill it with usually 500 to 1,000 of fluid, and we do it in the bathroom, and then they wait and empty into the bathroom. And this is a reminder of an ideal stoma, and you're not likely to see these very often, but if you do, you should appreciate the beautiful work of the surgeon because these are not common. The other things that you see are fairly common, and this is what we deal with as ostomy nurses. And so when you see these kinds of things, hopefully you kind of have an idea of what we do, and you will make referrals to ostomy nurses and definitely be doing your assessments. Big thing that I have seen as an ostomy nurse that breaks my heart, that I want to see changed, and I think that baccalaureate nurses can help me here, is that I have seen patients come to the clinic after their surgery and they're doing everything right. I had one little lady, she was so sweet, and she was only getting like a day and a half of wear time with her pouch, and all it was is that no one had taught her how to remove the plastic piece off of the backing of the pouch that to stick, and so it was a two-piece pouch, but she was doing everything right, but she was only using the release paper, which that release paper doesn't really hold it on. That's just kind of a secondary measure. So I'm not really sure how she got a day and a half out of it. So anyway, we should all be familiar with how to change a pouch and how to empty a pouch and how to assess skin and stomas. And I think that all of us can do that.